A spinal cord injury, SCI, is a damage to the tight bundle of cells and nerves that sends and receives signals from and to the brain. SCI can be caused by a direct injury to the spinal cord itself or by damage to the tissue and bones, vertebrae that surround the spinal cord. Therefore, this damage can result in temporary or permanent changes in sensation, movement, strength, and body functions below the site of the injury. Some injuries, especially those that cause lethal or no cell death, may allow for nearly complete recovery, whereas most severe injuries that happen higher on the spinal cord can induce paralysis in most of the body. According to James 2018, globally, the prevalence of SCI is around 27.04 million, with 0.93 million new cases of SCI in 2016. The United States of America, USA, has the largest prevalence of SCI compared to Japan, Australia, and Malaysia, with around 2,633,160 people. According to National Spinal Cord Injury Statistical Center, NSCI-SC 2021, the ratio of male to female cases is approximately 3:1, with greater male preponderance in young age groups. Spinal cord damage can be traumatic and non-traumatic. Traumatic injuries are caused by sudden impact of the spinal cord, such as motor vehicle accidents, which are the most recent leading cause of injury, followed by falls from a great height, gunshots, and stabbings, while non-traumatic are degenerative disc disease and spinal canal stenosis, development anomalies such as spina bifida, and congenital anomalies such as angiomatous malformations. SCI patients may experience one or more symptoms, including paralysis, which can occur suddenly or gradually as swelling and hemorrhage affect the spinal cord. Some people will feel numbness, tingling, and loss of sensations in their hands and feet, leading to loss of movement. Spinal cord injuries can be divided into two major functional categories: tetraplegia and paraplegia. Tetraplegia is a complete paralysis of all four extremities and trunk, including the respiratory muscles, and result from lesions of the cervical cord. Meanwhile, paraplegia is a complete paralysis of all part of the trunk and both extremities, resulting from lesions of the thoracic or lumbar spinal cord, or coda equina. Type of injury in paraplegia can be divided into three. First is complete injury when there is no sensory or motor functions in the lowest sacral segments, S4 and S5. Second is incomplete injury. Incomplete injury is having motor and or sensory functions below the neurological level, including sensory and or motor functions at S4 and S5. Lastly, the zone of partial preservation has motor and or sensory functions below the neurological level but does not have function at S4 and S5. The ASIA Impairment Scale, American Spinal Cord Injury Association 2008, is the latest updated criteria for assessing and classifying functional levels of SCI, including the definitions of complete and incomplete lesions. The assessment comprises 10 key myotomes and 28 dermatomes. A. Complete injury indicates no motor or sensory function is preserved in the sacral segments S4 to S5. B. Incomplete injury indicates sensory but no motor functions is preserved below the neurological level and includes the sacral segment S4 and S5. C. Incomplete injury indicates motor function is preserved below the neurological level and more than half of the key muscles below the neurological level have a muscle grade less than 3. D. Incomplete injury indicates motor function is preserved below the neurological level and at least half of the key muscles below the neurological level have a muscle grade of 3 or more. E. Normal indicates motor and sensory function is normal. Clinically, patterns of incomplete lesions are referred to as a syndrome. The incomplete spinal cord injury includes central cord, brown sac cord, anterior cord, conus medullaris, and cauda equina. After sustaining an SCI, the person is admitted to the local A&E or trauma unit. A full physical and neurological assessment is carried out, and a decision is made about referral to a specialist unit. Spinal imaging can provide reliable evidence of stability. X-ray, MRI, and/or computed tomography (CT). The decision of management, conservative or surgical, is made after the appropriate diagnostic testing. For physiotherapy management, assessment must be carried out as soon after admission as possible to obtain an objective baseline measurement of function, identify where specific problems are likely to arise, and initiate preventative therapy. The assessment include demographic data, doctor diagnosis, doctor's management, patient's problem, current history, past medical history or surgery, investigation, medication, home or social history or occupation, observation, general and local observation, palpation, respiratory examination, range of motion, motor control, muscle tone, sensation, proprioception, deep tendon reflexes, clonus, plantar response, balance, gait analysis, functional analysis, problem listing, short-term goal, long-term goal, as well as plan of treatment. As the physiotherapy intervention, the main objective in the acute phase are to institute a prophylactic respiratory regime and treat any complications, to achieve independent respiratory status where possible, to maintain full ROM of all joints within the limitations determined by fracture stability, to monitor and manage neurological status as appropriate, to maintain and strengthen all innervated muscles group and facilitate functional patterns of activity to assist in restoration of function where possible, and to support or educate the patient, carers, and family. In respiratory management, for acute trauma management, guidelines are well established. Management of patients with an SCI has special features resulting from spinal cord shock. Any evidence of desaturation or of falling saturation should be proactively addressed by the critical care team to maintain oxygenation and prevent further cord damage. If no other respiratory complications are present, the physiotherapist will teach breathing exercise to encourage chest expansion and improve ventilation. Incentive spirometer is useful for patients with mid-thoracic lesions and above. It is important to assist the cough when stimulating the cough reflex, as merely simulating the reflex will not produce an effective cough. As for range of motion, as the majority of SCI patients have an incomplete injury, it is important to facilitate and utilize any active movement available. During the acute phase, whilst the patient is immobilized in bed, the physiotherapist can assist in exploiting the potential for functional return. Where patients have any active movement, they should be encouraged to participate in activity, and it should be purposeful if possible. For positioning and turning, whilst managed on bed rest patients will require frequent turning to avoid pressure marking of anesthetic skin. Upper limb positioning of the tetraplegic patient is very important during bed rest. Incomplete cervical lesions are particularly prone to shortening of soft tissues due to muscle imbalance, resulting in partial shoulder subluxation and pain. Positioning is used to minimize spasticity, similarly to patients with other conditions. When the patient is exhibiting muscle, tone, inflection or extension, the limbs and trunk may be placed into reflex inhibiting positions. In preparation and initiation of mobilization, once doctor have confirmed spinal stability, mobilization is initiated by progressively sitting the patient up in bed. Postural hypertension will be the main problem, and patients with lesions at T6 and above will require an elasticated abdominal binder. This helps to maintain intrathoracic pressure and reduce pooling of the blood resulting from lack of abdominal tone. Once the patient starts to sit up, he or she will be supported in a hard or soft collar or a brace. Special adaptations to wheelchair can help to reduce hypotensive fainting. Example, reclining back and raised leg supports. When patient can sit up for an hour, they can initiate the more active phase of rehabilitation, working towards the restoration of functional activities. For pressure lifting, it's a technique in which patients lift themselves in the wheelchairs to relieve pressure. It is recommended that they lift every half hour for approximately 30 seconds. Where a patient cannot lift, a modified position in forward leaning or side to side tilt is used. In rehabilitation phase, the goals can be divided into achievable targets and should be patient-focused, appropriate, and objective. The objectives need to be set in relation to the level of spinal injury and the appropriate functional goals. This expectation for functions, depending on level of SCI, can only be a guide, especially in the light of the prevalence of incomplete lesions. For the bed mobility, rolling from side to side is thought first, then lying to sitting, and sitting to lying. Function is dependent upon the level of lesion. Example, C5, rolling side to side. C6, rolling, lying to sitting, and sitting to lying. C7, independent in all aspects of bed mobility. For sitting balance, sitting supported in wheelchair is progressed to sitting on a pin supported, unsupported, static, and then dynamic. Balance is practiced in short and long sitting. Hamstring length determining the ability to long sit independently. For wheelchair mobility, experience in using a variety of wheelchair is helpful when a patient is developing their confidence in wheelchair mobility. Essential principles of safety and wheelchair skills are taught. As the patient progresses, they should be given the opportunity to develop advanced skills such as very high curbs, slopes, uneven terrain, tight corners, and if possible, stairs and escalators technique. Adaptations such as extended brakes and a modular supportive backrest are required for higher lesions. Skills in powered chairs are based around safe use of the chair functions, maneuvering and experience of outdoor terrain. These chairs may have curb, climbing functions, and standing system. For transfers, it depending on the level of the lesions and functional ability. A sliding board may be used for legs ups and legs downs transfers onto the bed. This is progressed without a board where possible. Transfer then progress to lifting various levels for functional activities: high to low, low to high, between two plinth, floor to plinth, floor to chair, chair to car, bath, and to easy chair. In gait training, standing balance is achieved in the parallel bar in front of a mirror by standing in extension and resting back on the tension of the iliofemoral ligaments. The lifting technique is taught in the standing position, lifting the whole body weight with full control. Lift from sitting to standing and back to sitting is also taught. Once the patient has achieved standing balance and the appropriate degree of support required, dynamic balance work is started. This includes turning safely, swing to and swing through gait patterns, and the 4-point gait techniques for stepping practice. Functional electrical stimulation (FES) is a useful adjunct to improve a movement where only a flicker is first available. Similarly, electromyographic (EMG) biofeedback can assist the patient to move in the absence of full sensation. The aims of all such movement are to assist circulation, maintain muscle strength, prevent soft tissue shortening and contracture, maintain full ROM of all joints, maintain and remember movement patterns. FES exercises can produce isometric contractions, resulting in an increase in muscle cross-sectional area. In education, carers are actively involved in rehabilitation process and are taught how to assist with normal daily activities to support the patient in independent living. Assisted exercises, standing program, and chest care are taught in addition to moving